Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I am with Alex. How are you doing today?
I am doing very well, Dennis. How about yourself?
I'm doing very good. And the reason I brought you onto the podcast is you work for Massimo, and that's exactly what I want to talk about today is how do I run this thing like a boss? So if you don't mind doing just a real quick introduction of yourself.
Absolutely. So my name is Alex Drum. I'm the government clinical manager with Massimo. I was a 68 whiskey in my past life and a paramedic on the civilian side, and got sucked into the dark side. And so here I am.
Perfect.
I will say, sorry.
No, go ahead.
All the opinions that I'm going to express and talk about today are all mine. They're not Massimo's. Your standard disclaimer. This is me talking to you guys. It's not the corporate office.
Perfect. And that's exactly what we want. I just want the down and dirty, right?
Right.
So if you don't mind, would you just run me through some of the basic functions of the EMA?
Yes. So EMA capnograph, if you haven't seen it, it's this little handheld mainstream end-tidal CO2 device. This goes on the end of your ET tube or your pocket mask. You can go either way. You throw it on. Like all end-tidal, it's critical that you maintain a fully sealed circuit, and so that all the end-tidal CO2 that's exhaled is captured going across the sensor. If you have leaks in your mask, leaks in your tube, you're going to miss parts of that waveform. You're going to miss part of that end-tidal return, and you're not get the numbers you're hoping for. So just be aware of that. It runs on two AA or AAA batteries with standard. With alkaline batteries, you can get about 5 hours of runtime. With lithium batteries, you'll get about 10 hours of runtime. So just be aware of that. Pretty easy to put in. Big end always goes down on the device, obviously, because that's going towards the patient. So you're just going to clip in. You press a button, it'll turn on. Let's see. There we go. It'll turn on. Now, when it boots up, you'll see it comes to a screen that says 0. That's good. Sometimes, if it's been out and about, it's been rolling around your A bag, it might not be at 0. It might say 2, it might say 3. That means it just needs a quick calibration. So to do that, there's two buttons, one on the top and one on the bottom. You're going to press and hold both of those, and you're going to hold it for what feels like an absurdly long amount of time. The idea being we don't want you to actually trigger this and have it start calibrating while it's on somebody. It's also important when it boots. There we go. You see it kicked over. Now it's doing CO and it's counting down. Yeah. When that gets to 0, it's calibrated and happy.
Okay.
I think I let off one of the buttons a little bit.
Okay.
So it goes to 0. It's happy with itself. Now, When you first boot it up or when you're calibrating, do not have it on a patient or in a circuit where end-tidal CO2 is flowing by, because it'll then normalize to that level. I think that's the baseline, and that's not what you want.
Okay. So when I calibrate this thing, I got one too.
Yep.
Do I have to hold it all the way till it says 0?
Yes. You're gonna hit and hold both buttons.
Okay.
It's gonna be a little longer than you want it to be. You let off on one of the buttons.
Yep.
There we go. You see it's doing the CO 10, 9, 8, 7. You want to hold the buttons down through the whole countdown. 3, 2, 1. Boop, and now it's at 0. So now it's happy, and now you're ready to throw it on your tube, your mask, whatever, start monitoring and running.
Right.
Does that make sense?
That's definitely a little bit of a trick, but that's, just like changing your batteries or any kind of pre-mission or pre-run thing, make sure your EMA's calibrated. Especially if you're depending on that quality information.
Well, presumably, before you're changing the batteries anyway, you got a fresh set in there, so you're good to go. So it's pretty easy to fire it up, do that real quick, then put it all away.
Yeah. So is there any other kind of basic things that, like turning it off? Like, I got to tell you, that is the thing that frustrates people the most. Like, I've seen people just like rip the batteries out of it, or like that. There's got to be a better way.
you can remove the batteries if you're feeling sporty. The easiest way is just to pop out the circuit when you're done monitoring. It'll beep a couple times, but then it'll power down after 15 seconds.
Okay. So you put those expensive lithium batteries in it. You know, you don't have to waste them sitting in your aid bag. You know, just remove that insert, and then it'll power down.
And it's off.
Cool.
But I agree. When I first got these, because I was conventional side, so I never got a chance to really play with these. When I first got it, when I started here, I was like, could not figure out the off sequence. Because, of course, like anybody, I didn't read the owner's manual. I just got it out, started playing with it.
Yeah. I mean, why would you read it? You know what I mean?
Why read the thing those engineers took years to write for you? Right.
Right. But so, you know, those are some of the basic functions. And I got to be honest, that's some of the biggest frustrations is just like turning it off or, you know, it coming out of your aid bag, it's already reading 5. So you have to do math to try and figure out like, oh, the patient's somewhere, you know.
Yeah, calibrate. Don't do math. Don't do math. Not that you're not able, but you know.
Yeah.
One other thing, just for rarely is it a thing for people, but sometimes you may want to move your alarm variables up or down.
Okay. Yeah.
So if it should ever rise on here again, you'll see a button with an up arrow, a button with a down arrow. If you just press and hold it, it'll eventually, just one button, it'll flash low. And so now you're setting your low limit. So now you can use up and down buttons to move it to the value you want. And if it hits that number, it'll warn you. So maybe you're trying to bag somebody and keep them somewhere between 20 and 30. Now you set an alarm, and so it'll actually tell you if you're going outside of that. So you can open up that mental bandwidth to focus on other things. And no, I just need to glance occasionally, but it will catch and warn me. You don't have to hit like an enter or anything. Once you let up on it, it'll return back to the main screen. And then you can do the same thing and set that top barrier, and you're up and running.
Well, I gotta be honest, I didn't even know that was a thing. So
how often do you really need, you know, if you've got a vent with you, if you're lucky enough to have a vent with you, I could see that being, as a save 2 or something that doesn't have integrated capnography, I could see that being a value. Or if you're doing one of the guidelines for the traumatic brain injury, something along those lines, where you're keeping them in a different window than you're used to. Yeah. I can see that being useful.
Well, I mean, you're bagging your patient. Like, how many times has that ever happened in like medicine, right? So, you know, just knowing that, hey, I can actually set alarm, even if it's just like I'm going to default set it to normal parameters. Now you know that's a thing.
Exactly right. The other thing I can show you. Unfortunately, they don't make a great simulator for these things. I don't know, you can kind of see down there on the bottom, you get your waveform. So that's your actual end-tidal waveform, which we'll cover a little bit more in a minute. You get your respiratory rate and you get your actual end-tidal value on there. So just know you're getting those 3 metrics all the time. However, you have to make sure if you're doing it with a mask, that the mask is fully sealed. If you're doing it with an ET tube, make sure that's all situated. Because again, any air ingress in is going to throw this off a bit.
Yeah. And I've definitely, like, it's a handy little trick to put it on a pocket mask or some kind of, non-rebreather mask or something like that. Mm-hmm. Collapses pretty small. It's pretty handy. But I see guys, and those, especially like the non-rebreather masks, those things are like collapsed flat because it's stuck in your bag for so long. Yep. And then you pop it open, you know, because like if you're whipping out the EMA, like this is not just like a basic patient. You're definitely in a world of hurt, right? So they put it on the patient, and like the seal is horrible. You know, you got douchebag patients like me that's got a beard, and like it's blatantly obvious, like you do not have a good seal, and like that's in our where I work, we have a training course, and I've seen people just freak out because like, hey, your EMA says 25. and they like don't understand that. Like, no, you have a crappy leak. Like it's
Right.
like blatantly obvious. Like you have an enormous leak, and you have to fix it.
And you guys have never thought about just having pre-cut wax strips you put on and just defur the face?
I mean, a pre-cut wax strip that's pretty high speed. I got to be honest. It's like if you have pre-cut stuff like that, I've seen gel work real well.
Sure.
Chest seals or any Tegaderm or something like that. I've seen work pretty well.
I never
but
thought
just
of that.
even
That's smart.
But even just like the basic concept, like you don't have a good seal, your
Right.
numbers are going to be off. Is just like blowing people's minds. You know what I mean?
Yeah, and significantly off too. It's not.
Yeah.
It really needs that closed circuit to provide you with the data you're looking for if you want to really
Right.
trust it.
Right. So
And I would say, I know you mentioned it's only for pretty critical patients, and that is true. 'Cause most of the time there are two, but there are some fun party tricks you can do as far as hooking it up on a patient and doing a passive leg raise. Have them lay on the ground for a little bit, and you can see how many soda pops they'd had the night before. You can tell how dehydrated they are, basically their fluid responsiveness. It's
really?
Yes.
So
Yeah, so
I guess what happens?
So yeah, you lay them down, you let them kind of, and again, this is a party trick. This is not a diagnostic
Sure.
statement. Lay them down, get their end tidal, see what it is, and then prop their legs up and see if you got
Yeah.
a bump. If you got a bump of several millimeters of mercury of end tidal return, they're fluid responsive. The bigger that gap, the more fluid responsive they are.
Oh, really? I mean, not like cornering you into like some kind of a clinical diagnosis, but say you get a 5 or 8, is it centimeters of water or is it
Millimeters mercury.
millimeters mercury difference? Does that correlate to any amount of volume?
I don't. Somebody out there in your audience probably knows. I don't. I'm not wise enough to know these. I just know you're adding to the preload and you're able to see in the output side what
Okay.
what
So they
volume
could,
pent up.
you got like a heat injury of some kind. At least like, hey, this guy could probably use at least a drink of water, right?
Right.
Whether that's orally rehydration or if you're really desperate, a 500 bolas, something like
Right.
that, and then just keep measuring that until the guy is like coherent enough to do it on his own.
Well, it's the easy thing when you're doing your other checks. I'm assuming the soft medics, just like the conventional medics with the line unit, are doing their checks when you guys are doing force movements and stuff. It's an easy enough tool to pull out, spot check, see what's going on, and just see what you think.
Yeah,
It's interesting.
So, I mean, other than,
sorry.
I'm sorry, I cut you off, but other than, so I've heard it said many times, an EMA or some other kind of capnography, is a kind of a poor man's cardiac output monitor, right? And you definitely have to know your stuff in order to suss out, what these changing in numbers mean.
It's one value, right? It's one piece of the puzzle, but
Yeah.
you start putting together with other vital signs and observations you made of the patient. And it's a pretty valuable piece of the puzzle.
Yeah, 100%. And I tell my students, like, never rely on just one vital sign to really drastically change your treatment. You know what I mean?
Yeah.
Because there's other things. It's just, are you observant enough to pay attention?
And that is the rub. That is the rub. Cognitive burden is a real thing when there's a lot of noise to find the signal and all that noise and lock on.
Yep, absolutely.
And knowing what normal is and using these tools, not just at the point of injury on a really bad day, but using it on a good day when you're out of the range of somewhere else, so you kind of know what normal is for these things.
Right.
In my humble opinion.
So what I see a lot of guys use this for is, airway confirmation. Like that seems to be like the kind of mainstay, and it is the gold standard when it comes to airway confirmation.
Yep.
I would say it's one thing I see guys have a problem with is that they put it on real quick, get a number, and then they're like, okay, I'm good. You do have to wait for the, I believe it's 6 breaths to actually like get a true number, because guys forget, like, there's people burp, people, you have gastric insufflation, you have other things that can cause some kind of CO2 release.
Well, is
that true?
I'm a fan of. Well, that is true. That is true, right? Because if it's just like anything else, if you put your fingers on somebody and feel their pulse for a second, multiply it by 60, that's not actually going to be what their heart rate is or respiratory rate, right? So you want to get a longer sampling window to see what all is going on with that patient. And I'm a big fan of also the waveform. It's not just the metrics and the fact that you have a waveform, but there's things that waveform can actually tell you about your patient and about your therapies and where things are going. So I think it's important to throw it on if you can. If you have the luxury of one patient, leave it on so you continue monitoring them. Because I know even on the civilian side, away from everything else, accidental extubation happens during patient movement. And, that is in a very generally calm civilian environment, doing a sheet transfer or something else. Your listeners are doing it in places where it's a lot rougher to move people around, and a lot more moving around going on.
Like there's not a lot of branches in the hospital. You know what I mean?
Right.
So,
So I would argue that leaving it on is a better call. And I understand if you have one EMA, multiple injured patients with airway issues, I get it. But if you have the luxury, I would say leave it on. Get the most data you can get out of that patient.
And I normally would 100% agree with you, especially when you're talking about, patient transfer. You're transporting in a some kind of vehicle that it's dark, it's noisy, like. You honestly have no way of knowing, is this patient breathing or not? Like you can fool yourself, but you actually have no way. The one thing I don't like when guys just leave it on is it's a weight on the end of your ET tube or your crike. And I've definitely seen that weight start to at least dislodge things, if not
fair enough,
extubate almost completely, just because they also are not securing things super well. You just slap it on a chest tube chest seal. You're just kind of relying on the stickiness of this thing on a patient who's sweating or bleeding. And, it doesn't really sit real well. So you have this extra weight on it, and I've seen it pull it all the way out. Even though it, I don't know, it's just weighing it here, a couple ounces, definitely super light. But I've seen that extra weight extubate a patient before.
Sure.
But that being said, in that kind of transport mode, or if I'm actually monitoring it, so it's not just on there giving numbers that nobody's paying attention to. But if I'm actually sitting there monitoring this, like I'm doing some kind of vent management, it's 100% worth it because, I'm focused on, I'm actually focused on the numbers and what the things that it's telling me.
Right.
So, we kind of went through, it's great. It's the gold standard when it comes to airway confirmation. Is there, and I mentioned, vent management, just getting your numbers and adjusting rates and depths with it. Mm-hmm. Is there any other things that it's very useful for?
There's a lot of data on using it in triage and using it in patients where you're trying to determine how much salvageability is there? Even on the civilian side, when we're looking at patients and you have an end-tidal, with a full breath and the end-tidal return is less than 10, less than 12. Outside of a couple one-off situations, that's not a good sign, right? There's not enough cellular activity. The Krebs cycle is frozen. Things aren't happening. That's not good. And there's not a lot you're going to fix in the field. I know there's a lot of studies that look at traumatic triage using end-tidal CO2. And it's similar. If that number is that low, the odds of them making it, particularly in an austere or remote environment, all the way through the continuum of care to the surgical intervention they need in time is not strong. So it's good for that. Determining or detecting ROSC, whether it's a cardiac arrest or maybe you're finally filling up the tank with enough blood to see a return of perfusion, you'll see that number, low, and then you'll see it climb rapidly, especially with cardiac arrest and ROSC. It's a pretty marked change. You'd spot it pretty quick. Yeah. It's really actually pretty phenomenal to see.
Yeah. I mean, and it is dramatic. Like you'll see, like, you mentioned 10 with a doing triage. I mean, just CPR, you should be hitting 15. So
exactly.
So things are bad off, and in that kind of environment, you may not have the time to do a code on this patient.
Right.
But I've seen people, they're getting blood, and you got, your low or mid 20s type end-tidal, and I've seen it like jump, like 60s, 70s, you know what I mean?
Exactly. No, it's a phenomenal change when that system kicks in and it starts perfusing and carrying all that waste out. It's amazing. Yeah, it really is.
It is. And like I said, it's pretty dramatic. But you mentioned previously about waveforms. So if you wouldn't mind, would you help me kind of, just know what the frick I'm looking at? So,
Sure.
If you don't mind, I got some pictures of waveforms. So this came from Foam Frat. So shout out to them for putting all this work into it. But if you don't mind, the teacher in me can't help but quick explain this part. But if you can see my cursor, so all this is, essentially no air movement. That's why you have this dead space.
CO2 movement.
Right.
Yeah, no CO2 movement. So I think of that as like the isoelectric line on an ECG, right? That's kind of the floor, if you will. Yeah. And so that's why calibrating is important, because that's setting what true zero is for that place you're at with that patient.
Yep.
Right.
Absolutely.
So that way where that floor is. If you accidentally have it at 5, your whole floor is offset, and now you're going to miss some of the detail with what's going on. So you can see there, the inhalation is basically 0, right? Because that's air coming through with just normal atmospheric levels of CO2. You can see the start of that slope up as the mix in the dead space, as you start seeing the air that was kind of sitting in between your mouth and your carina, kind of that area hanging out, doing its thing. It starts to mix. You get to the full alveolar exchange where it's all the CO2 coming out in the breath. And then it should, in theory, have that little, you can see it's a very subtle, but a climb from left to right where it's going to go kind of up. That is where it's at that beta angle. That's where it's establishing what your end-tidal CO2 number is. That metric, the numeric, comes from that point right there.
Okay.
And that's kind of the end of your exhalation. And then you can see it drop off, because now you're inhaling, so you're drawing fresh air across the sensor. You're clearing out all that CO2 that was being blown out. And especially on the EMA, there's only 6 milliliters of dead space in there, so it's very small. And some other types of end-tidal CO2, there's the tubing, that runs in between the two. It can add a little bit more dead space. It may change the waveform a little bit, so just be aware of that if you're looking at other stuff. Be very, very similar, very close, but just be aware it may round off a little bit more.
Okay. Yep. 100% makes sense, and then it returns back to your baseline. Obviously, ideally, right?
Ideally.
So, so I've kind of arrange these kind of in a march sequence. So you mentioned about, airway confirmation. So, when you're monitoring, you have your normal waveform, but then things start going awry. So is this like air leaking? Like, is there any way to tell like why this is happening?
Well, I mean, I think looking at the waveform and then using your clinical judgment on the ground of, all right, well, what type of airway am I using? Am I using a mask? If I'm using a mask and I'm seeing this, and I can feel as I bag them, or that their breath doesn't change that much, then I think I have a leak. And I would say similar if you have a tube, whether it's a trach or some other airway type, it would be the same thing. You have to observe the patient. How's that chest rise and fall? And does it line up with what I'm seeing on there? If not, there's probably a leak somewhere. And you just need to kind of go through your problem solving matrix to find where and what the issue is.
Yep. And then speaking of your problem solving matrix, you have the dope mnemonic, right? But again, all of this is this is all bad, right?
Yes.
You have normal waveform, and then suddenly you got nothing. Immediately jump into your dope mnemonic, dislodgement, obstruction, pulmonary, pneumothorax, and then potentially maybe it's your gear that the battery's died, or who knows what's happened. But you got to jump on that as rapidly as possible.
Yes. Not breathing is not good.
Yeah.
Just to sum that up.
So things like this, like the shark fin, what exactly is going on here?
So it's your in bronchoconstriction. So think of like your asthmatic patient or some other traumatic airway constriction. It's a little harder for you to get the air out as fast as you want to get it out. As you see it kind of that rounding as you're kind of pushing that air out, you're fighting to get it out of you. And then it comes up, and then you go back to your inhale, and you inhale fine, and you pull it in, you clear that tube, but then your exhaling just takes a little more effort to get that clear. If that makes sense. You see that rounding versus that sharp inhalation. Your diaphragm drops, but the air is struggling to get out.
Right. So, classic, I guess, emphysema, but I guess how, like they mentioned pneumothorax, why would you have a down angle? What is that, your phase 3 or 2, your phase 2? This alveolar line, why would that be a downward angle?
Because the air is the CO2 is finding a different pathway to escape. It's not coming out through your tube, right? It's coming out through a hole in the chest wall somewhere.
Okay. So this may not be just in the chest wall. This could be damage to the actual lung itself.
Right. Yes. Yeah. It's finding an alternative way to get out.
Okay. Just out of curiosity, so we had mentioned this corner is where the monitor is going to get your number. Does it default to whatever the highest number is, or is it in this phase?
It does default to what the highest number is. Just in a physiologically normal patient, it would have been the right hand side. You're right. In this patient, it would actually pull it from the left.
Okay.
Yeah. So whatever the true highest number of that return is.
Okay. So some other stuff. I see this all the time, right?
Absolutely. As have I. So yeah, you can see with every breath, because they're taking such a rapid cadence, you can see there being less and less of a pool of CO2 to pull from. And so you see them blowing it off, presumably from 45 down to, I don't know, 25, 30, somewhere in there.
Mm-hmm. Yeah.
And that's obviously not necessarily a good thing.
Right. But I mean, that can be, again, like we mentioned before, not relying on just one parameter to tell you, this is what's wrong with them, because this could be pain. This could be they're bleeding. There's a bunch of reasons why, they're starting to lose end-tidal CO2. And all of this is just a normal physiologic response from the sympathetic response. So, definitely do not just rely on one number to tell you this is what you have to do.
Well, this could even be your rescue buddy over bagging, right? That's where I saw it a lot with firefighter helpers sometimes doing CPR. They're watching you do compressions. They're pumping at the same speed you're compressing, and you see the same slope off. And I mean, if it's one thing, if a patient's hyperventilating because they were just sprinting to try to get to you because they're scared, because whatever else is going on, there's a ton of reasons. Preferably, you don't want to see them continue that. Whatever ride they're on, you want to change it up.
Yep. And that's just a normal, I think, human reaction to do. So, we talked about bleeding. So essentially, the guy has a pretty normal rhythm, but he's just slowly kind of dropping off that CO2. So, you're at, say, normal is your perfect. As they're bleeding out, they just have those less and less RBCs to catch that CO2 and bring out through the lungs. So they're just slowly losing that CO2.
Why getting away from crystalloids is such a good move, right? Getting the things that actually carry oxygen.
That's right. So, like you just mentioned, getting things that carry oxygen, not just, doing CPR, do you get ROSC, but just giving blood, right? So you have these really low end tidal numbers, and then suddenly, you hit them with, 1 or 2 units of blood, and boom, this thing jumps way up.
Yep. Yeah, it really is pretty marked to see. It is that big of a change in patients, especially in cardiac arrest. When you get ROSC, it's pretty awesome.
Yeah. So, like you just mentioned, your patient is getting overbagged. They're starting to stack breaths. So that it's the reason why they're not kind of returning back to that zero is they're stacking breaths. So that pressure is kind of building and building, right?
Or you could have your exhalation circuit could be too long where their breath isn't fully clearing it. You've introduced too much dead space, right? And you need to find a way to either clear that with oxygen or clear that by shortening that chain. For whatever reason, they're keeping a little more end-tidal CO2 on every breath, because you'd see that same isoelectric line like we talked about. What was 0 in the beginning is 1, 2, 3. It is growing. So they're not getting the clearance out for whatever reason.
Right. One thing, I have never seen it grow like this, but I have seen it, just be just above 0 is when you add PEEP onto that circuit. Right. And it'll never come back to 0, or it should never come back to 0. But it'll stay consistent, but it'll stay at whatever that number of PEEP that you dialed it to. So it's 5. Right. If you move it up to 7 or a number bigger, you're going to see it grow. But again, it'll be consistent across each of the waveforms there. Right. So kind of moving on to some of the others, right? Hypoventilation. So, classic thing, and it drives me kind of crazy, is because somebody will say they're not breathing normal, make them breathe normal. And, like that doesn't, like normal numbers in an abnormal patient doesn't make them suddenly better, right?
Right.
So,
right.
But I've seen this particular waveform very commonly when they just slam people with narcotics, and that respiratory drive, they start to kick the legs out from underneath it, and they're breathing at 5, 7, something like that. And, people start freaking out. He's satting fine. You just, overdose this guy. So they'll start bagging them, and then, the wheels start shaking, and, bad things start happening, And
it happens quick once you start going down the hole.
Right. Then the last one I was going to look at, or I'd like to talk about, is this Curare cleft. So this is super, I guess a classic sign your paralytics are starting to wear off. is that affected also by your sedation, or is this solely your paralytics?
But anytime somebody's coming out and trying to breathe on their own,
Okay.
and breathe outside either your vent or your bagging, you could see the same demarcation. At least that's my understanding, is that is associated with the patient's attempts to breathe in.
Okay.
In the middle of
because I've seen things like this. Sometimes it's a little more chaotic across that plateau. But the patient's starting to come out of sedation, and because it's, they're not kicking or, anything like that. They're just starting to come out. This kind of gets overlooked. And this is kind of your first warning that they're starting to want to breathe on their own, which is a great sign if that's exactly what you want them to do. But if it's not, that's your indicator that they're going to need more sedation to take control.
Exactly. Yeah, it's fun. It's good when you're hoping to bring them out, but it's not something you want to see if you've got a long transport and you weren't planning on that.
Right.
Or your mid procedure.
Right. So is there anything else, I guess, that we need to know about, whether it's be waveforms or just anything about the EMMA that you wish, king for a day, you knew that people knew about, the EMMA?
I mean, thankfully, I think, especially in your community, I think a lot of people were familiar with it. The conventional side, some people were familiar with it. We don't have quite it's not out in every aid bag yet, and I think it doesn't really tie directly to just EMMA, but to all the gear. I think it's guys need to get it out and use all your gear, stethoscope, blood pressure cuff, your pulse ox, all your stuff. Use it on healthy patients. Use it not when everything is going horrible. So what does normal sound like? What does normal look like? How does this perform on a patient that I know is healthy, or maybe he's not that healthy. Maybe he's a little dehydrated and he fell out on a ruck march, whatever. Putting those reps and sets in early, and that's, again, EMMA, whatever. I think that is the most important thing a medic can do, to me, in my mind. And so they're comfortable with the observations they can make and see and learn and correlate in their own internal dialogue is going to help them bring more patients back next time, help more guys out, and it's only going to help them grow.
Yeah.
So, like I said,
you're 100% right.
For everybody.
Yeah, you're 100% right, because I've seen guys just excited as hell. They're like, I have the EMMA, right?
Right.
And this is not Jesus' blood. It's a device. Right. It's a device, right? You have to know how to use it.
One data point, important data point, but you need to look at the whole picture, because I could throw just random numbers at you all day and like, what do you think's going on with a end title of 45?
Yeah.
Like without all the rest of the picture, it doesn't make any sense. But it's super, super handy if you have it and you have the rest of your picture. It's a lot of info.
Yep, absolutely. So let's say I'm a medic by myself. I have to pay for everything on my own. How would I go about, contacting your company, or like how would I even go about trying to order this?
Yeah, so you contact us. There are a ton of ways. We do have awesome resellers out there, depending on your branch. But you'd also go to massimo.com and get a direct from us. So yeah, you can reach out to me. I'm happy to help out. I'm all over LinkedIn, usually stalking Dennis. So I'm here to help.
Cool. Well, I mean, I gotta say, I really appreciate you walking me through the EMMA and, what can it do?
Yeah. I really appreciate the opportunity to come on and talk about it. I love this thing. I got to play with it a lot, but I don't got to talk about it to my computer a whole lot. So this is exciting.
Cool.
For today's podcast, be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. out.
Boy is waiting there for you.